too much time, we would want to dive into today's lesson. I think the time is fast spent, so Prof, you're welcome. You can kindly go
Thank you.
ahead.
Thank you. And you can hear me okay, right?
Yes, please. The sound is
Perfect.
very fine today. Yes,
Very
please.
good. Very good. So apologies once again, and thank you to
It
the
is
participants
accepted.
yes, for waiting. But I can promise you it will be worth it because today is going to be one of my favorite topics. And also, this is now in direct preparation for the hands-on sessions that we will be having when we meet physically in Ghana. So today we'll be focusing on forceps and vacuum, that is operative vaginal delivery. Now, I'm very sure that many of you are very familiar with this. But what I'm going to be explaining, apart from the little bit of introduction in the beginning, just so that everyone is on the same page, and maybe those of you who are not as experienced as others, we give some background. But then I'm going to be explaining this, what we call a mnemonic, so like something which helps you remember, so that when you need to carry out operative vaginal delivery, you need to intervene to expedite delivery for whatever reason, right? And in that moment of urgency, like, and panic to some extent, when you have something which, you remember automatically, it's like autopilot, right? So those are what we are intended by skills and drills. So maybe, you're not doing a forceps delivery every day or a vacuum extraction every day, but, when you're called in, maybe in the middle of the night to do such a delivery, it needs to be in your muscle memory. And with the presentation that I have today, the intention is to make this procedure, right, whether it's forceps or vacuum, literally as easy as ABC, and I mean ABC because the mnemonic is ABC, as we will see very soon. Okay, so let's start with the objectives of today's session. So, of course, we'll start by discussing the indications and prerequisites for vacuum and forceps use during delivery. We'll also discuss the pelvic landmarks and define the instrument procedures. That's basically the ABC mnemonic that we're going to be using. And while doing so, we'll also be demonstrating the proper use of the equipment on the maternal fetal mannequin. Now, I want to also highlight here, both of those of you who are listening live and those of you who will be listening to the recording, that, this particular session is very, very important. You know that at the end of this series of sessions, before we meet physically, there's going to be a test. And definitely the test will include today's session for sure. It will include all sessions, but there will be quite a lot of emphasis on today's sessions and also the sessions which are coming up next. And why? Because we need to make sure that we know the theoretical part very well, so that when we meet physically and we're doing the hands-on training, you already have the background. So that makes us more efficient in time when it comes to then practicing hands-on. So rather than having to explain again all the theoretical part, you are already familiar and you have already grasped it. So then we can make the best use of time when we meet physically to each of us practice on the mannequins on how to carry out these, in this case, the vacuum and forceps extraction. All right, so when we talk of assisted vaginal delivery or operative vaginal delivery, it is an important skill for managing the second stage of labor. Of course, not all patients, definitely not all patients need assisted vaginal delivery. However, as I said, when you're called in to assist in the vaginal delivery, especially for forceps and vacuum, you need to have the knowledge and the skills to do it in emergency situations. Okay, what I didn't go into in this session is cesarean section. I'm sure you're all familiar with cesarean section. And although you might say, okay, in emergency situation, I might do a cesarean section. Of course, it is an option, but it's not always possible. If you have a patient who is on her way to hospital and there is an emergency and you need to expedite delivery, or for example, let's say the operating room is busy and you can't, do multiple cesarean sections at the same time, of course, there is room for assisted delivery. Plus, there are cases, as we will see, where the head of the baby is so engaged that it's safer to do an extraction rather than going for cesarean section. No? All right, so what instruments are we talking about when we talk about assisted delivery? So it's vacuum extractors or forceps. And when we talk of vacuum extractors, from what I understand, you're more familiar with the rigid metal cup. That is the one which you find in most hospitals. I mean, even locally, we have that rigid metal cup. I mean, the name is Marstrom. However, I'm going to talk to you also about the soft plastic cup, and particularly the kiwi. I mean, there are multiple versions, but the kiwi soft plastic cup for vacuum extractor, for vacuum extraction, that is something that we introduced in our unit, I think about 10 years ago. So around 10 years ago, I was in charge of introducing the obstetric skills and drills in the department, and I had read about this kiwi, which was being used in the UK and on the continent, and we introduced it. And although it doesn't replace the rigid, because there are times when you need to use the rigid metal cup, there are occasions where the soft cup might actually be better, especially because the rigid metal cup, it needs to be attached to a machine. You need to have the vacuum actually. So you need electricity and you need the patient to be in the delivery room, with your machine. While the soft plastic cup, like the kiwi, I think I have a picture, yes, I have a picture there, you don't need electricity. Okay, so this is the one you're probably familiar with. So you've got the vacuum pump and you attach it to the electricity. You could also do the vacuum extraction manually. I mean, the creation of the vacuum manually, of course, that's going to take more time. And then you've got the rigid cups, the rigid metal cups, which of course can be sterilized, they can be reused, and they come in different sizes. So they still have their place on the delivery suite, but the soft cup, all right, so this is the kiwi. There are other types of soft cups, but this is probably, let's say, the most commonly used. This is not attached to a vacuum or to electricity because the cup itself, I mean, has this cable over here, which is hollow, and it's attached to this manual pump where you don't need to stay pumping for a long time. It's usually about 3 pumps that you do. And then as you pump, this rod over here comes inside the barrel. And once you reach the green spot, so as you're pumping, you reach the green spot, then it means that you have applied enough pressure and therefore you can pull on the baby's head. Okay. This, when I come, I will get you samples of these. So you can actually experience it. And also when we're going to be doing the vacuum extractions on the mannequins, on the plastic dolls, we'll be using this. Okay, so you'll have the opportunity to try it out. And of course, as I said, there's still room for the rigid metal cup as well. And when we talk of forceps, there are different types of forceps. And nowadays, the one which is used, even though, as I said, I mean, not every labor ward, not every delivery suite actually really resorts to forceps, but I would dare say in our practice, there are a number of obstetricians who resort to forceps, but the ones which are used is either the Simpson or the Neville Barnes. Basically, Simpson and Neville Barnes, they're more or less the same. It's just Simpson was, let's say, named after an American obstetrician. Neville Barnes was a UK. It's more or less the same shape. And this is the one that, when used for forceps extraction, these are the ones which are used. It's all-purpose, it's most suited, especially if the head is very molded, right? Especially if the mother has been in labor for a long time, and there is some degree of obstruction which is not allowing the delivery. And then the other one that we tend to use, not as commonly, but tends to be used, is the Wrigley's. Basically, the Wrigley's is similar to the Neville bars, but it doesn't lock. And I mean, it doesn't have a lock. I mean, even though when it fits, it doesn't slide. And it has much shorter shanks. And then the Piper, the Elliot, again, there are more or less versions of the Wrigley's. And then there is the Keeland. The Keeland, we don't use it anymore. I think I mean, in my 30 years in obs and gynae, I've maybe seen it used once by an elderly obstetrician, and we don't use it anymore. I mean, if there is an indication to use a Keeland, we don't use a Keeland, we go for cesarean. And I'm not going to spend much time on the Keeland, but the idea of the Keeland used to be that you apply forceps, you actually use it to rotate the head of the baby and then deliver. However, of course, it is associated with increased maternal morbidity, increase in tears and bleeding, and also increase in morbidity on the fetus, on the baby, and therefore now, it's, I would dare say, in Europe, I mean, it's been abandoned. And if there is such an indication where the baby needs to, is malpresenting, you don't go for a key and you go straight for cesarean section. Okay? The Wrigley's, the one with the short shanks, um, it's used especially if you're doing a cesarean section. It's an emergency section for someone who has been in labor and the head is well engaged. And in order to help lift the head out of the pelvis during cesarean, there are a number of obstetricians who resort to Wrigley's. Okay? It's more of personal preference. Personally, I don't use the Wrigley's in that case, but there are other obstetricians who prefer to use the Wrigley's rather than kind of extract the head with their hands. So some examples. So what I was talking about, with it being the most common, is the Simpson. There's the Simpson here, and this is the Simpson, which is also known as the Neville bars. So you've got the lock over here, you've got the cephalic curve and the pelvic curve, and of course, because of the pelvic curve, you can't use this for rotation. And nowadays, you're not meant to use the forceps for rotation. This is the key lens, which, as I said, we no longer use. We do have a pair on labor ward, but they're for demonstration purposes. We just use it to teach medical students and midwifery students and nurses, but we don't use this anymore. And the difference between the key lens and the Simpson, the main difference is that they slide, the two blades slide on each other, and that you only have the cephalic curve. So technically, you can rotate the key lens forceps within the pelvis. This is the Wrigley's. To be honest, this one, the other Simpson with this number here, is also the Wrigley's, really. And what you notice is that the blades more or less are the same size, but there is a much smaller shank. And if you remember your days when you were learning about physics, and the fact that you have shorter shanks, shorter handles, the momentum, not the momentum, sorry, the leverage when you are extracting the head, you have less force that you can apply on the head. So, of course, this is not useful at all if you're doing an extraction like during vaginal delivery. It will just keep on slipping and, of course, cause more trauma than benefit. But, I mean, it is used by a number of obstetricians, as I said, when they're doing a cesarean section and the head has already engaged. For example, she's been in labor for a number of hours and the head has engaged. And in order to extract the head from the pelvis during the cesarean section, some obstetricians use this because, of course, once you have the womb which is open, I mean, you don't need so much leverage. All right. So when do we go for assisted vaginal delivery, for operative vaginal delivery? And there are a number of indications. They could be maternal indications, they could be fetal indications, and they could be delivery related maternal-fetal indications at the moment of delivery. So let's start with the maternal indications. I mean, of course, you could have cases where the mother is already suffering from an illness. For example, she has a cardiorespiratory problem, let's say, I don't know how it is in Ghana, but certainly here we're seeing more, let's say, elderly mothers having babies. And of course, with increased age, they're more at increased risk of getting, chronic hypertension, pre-existing chronic hypertension, and they tend to be more at risk of developing heart failure during pregnancy, especially if there are comorbid conditions like obesity, smoking, etc. So these patients, I mean, they would be compromised cardiovascularly, and of course, although you do allow them to have a normal delivery, but you might want to shorten the second stage of labor in order to reduce the stress on the heart. Same if you have patients with respiratory conditions. And again, I mentioned smokers. Unfortunately, smoking is on the rise in Europe, and also asthma and other respiratory conditions. And of course, you could have other conditions like, let's say, intracranial episodes. So let's say, again, a mother who in the past suffered from an intracranial bleed, and she's at risk of having an intracranial hemorrhage. And in that case as well, you want to shorten the second stage of labor. And of course, in the ideal situation, in the ideal situation, before the patient actually gets pregnant, in the ideal situation, her pre-existing condition, whether it's cardiorespiratory, whether it's intracranial, gets improves. That is, she gets the right management so that her underlying condition is the most ideal possible, so that it doesn't worsen that much during pregnancy. But inevitably, as I've mentioned before, pregnancy is like a stress test for the body. So you might not even be aware that you have a pre-existing medical condition before you get pregnant, and then it kind of shows up in pregnancy. And in that case, you might want to shorten. You sometimes have to shorten the second stage. And another common condition that we get to see is also patients with retinal with eye problems, with retinal detachment, like history of retinal detachment. And again, in that case, you want to shorten the second stage. And the other reason why you might want to expedite delivery by using assisted delivery is if the mother is bleeding, right? If the mother is bleeding as she is in her second stage, of course, you want to hurry up, with delivering the baby. Other conditions where the mother has started pushing and things overall are going well, but the second stage is taking too long. I mean, these could include, very commonly maternal exhaustion. So even if she's having analgesia, but pushing, for 2 hours or beyond, she might need help because she can't push as well because she's exhausted. It could also be that part of her inability to push properly, right, and therefore leading to a prolonged second stage, is if she's receiving analgesia, which is drug induced. For example, she's received morphine or betadine, which is making her more tired, and therefore she can't push as effectively. And of course, there could also be soft tissue resistance with failure to descend. And you might tell me, but why can't you do an episiotomy in that case? You can do an episiotomy, but of course, the mother still has to push, um, to overcome that soft tissue resistance. And again, for example, doing a vacuum extraction might help with the head to descend and therefore to allow the delivery. And of course, any other causes of prolonged second stage. So what do I mean by prolonged second stage? So when we're talking of a patient who in her first pregnancy, in her delivering for the first time, normally, we time the start of the second stage, so the start of the pushing. And if they are not receiving any regional anesthetic, especially epidural, there is in Malta and in many countries, there's quite a high uptake of epidural analgesia, where you numb the perineal area and even the lower limbs, and the patients don't feel the urge to push that much, So in fact, when she's 10 centimeters dilated, you need to reduce or stop the anesthetic. But if she has no regional anesthetic, so she doesn't have any epidural, the second stage is she keeps on pushing for 2 hours, but beyond 2 hours, you might need to expedite delivery, especially if the baby is showing signs of fetal distress. If there is regional anesthetic, just because we know that there is a problem with the mother, because she might not feel the urge to push, and therefore she might not be pushing properly, it is okay to wait for 3 hours, of course, as long as the fetal heart is normal. If she's a multiparous lady, and therefore she's expected to deliver quicker, right? The second stage considered prolonged if she is pushing for more than an hour and she's not having any regional anesthetic, or 2 hours if she's having epidural. Okay? We just use these because given that a number of indications for using vacuum extraction are centered around prolonged second stage. Therefore, that's why we time, and because then beyond that hour, beyond that time, it would be justified to do an assisted delivery. And again, I don't know how it is in Ghana, but here we are starting to see quite a rise in medical legal issues. So if, for example, a lady first baby has been pushing for 2 hours without using anesthetic, and then we wait, before we intervene, and then the baby is born and the baby has problems, as a consequence of fetal distress, patients are more likely to sue. And that of course you don't want to cause damage in the first place, and also you don't want to the situation to end up to to lawsuits. So of course we have to make sure that there is documentation in place to keep everybody safe, the patient, the baby, and even the team who is assisting the delivery. So it's very important documentation. It's very important. And in fact, I'm going to make a reference to proper documentation when you're doing operative delivery. So same way that when you do a cesarean section, you write down in your operating notes and you write all the details. The same thing you have to treat when you do a vacuum extraction or a forceps delivery. Documentation is very, very important. All right, so we were mentioning the maternal indications for assisted delivery. There are also maternal fetal indications. So that's when you have a relative cephalopelvic disproportion. Now, why did I say relative cephalopelvic disproportion? Because, of course, if there is, full cephalopelvic disproportion, meaning that the fetal head has not engaged, right? Still at 5/5 palpable. In that case, you don't even dream of doing an assisted vaginal delivery. That patient will need to be delivered by cesarean section, right? Because, if the head is not passing through the pelvic inlet, then there's no way that you can extract because you'll cause more damage to the mother and to the fetus and can lead to torrential hemorrhage, among other things. So relative cephalopelvic disproportion. So by that I mean that the fetal head has started engaging and is at least at 2/5 palpable. At least, I mean 2/5 palpable or 1/5 or 0 palpable, but at least 2/5 palpable. If it is like 5/5 palpable, 4/5 palpable, just go for cesarean section. Okay? Of course, if she has been in labor and she has contractions, but the baby is stuck, and the baby is stuck. All right, but if it is relative cephalopelvic disproportion, meaning that the head is at least at 2/5 palpable or 1/5 or 0/5, then and she has been pushing for 2 hours and you have good contractions, in that case, yes, you can consider going for an assisted vaginal delivery. Of course, if there is a malposition, meaning malposition like occipito-posterior, right? You can do forceps, or you could also do vacuum. And of course, because the mother could deliver on her own, but with occipito-posterior, since the diameters are not the most favorable, then she might need assistance because the second stage is very prolonged. And also if you have a malpresentation, like for example, face presentation. Now, when it comes to face presentation, really and truly, the face presentation, which can be delivered vaginally, now whether it's with assistance or not, is the mento anterior. Mento anterior meaning that the chin is anterior. The chin of the baby is basically next to the mommy's tummy. Because if it is a mento posterior, meaning that the chin is towards the back, is facing the maternal sacrum, all right? Mento posterior doesn't deliver. To remember it, you know how I remember it? I say MPs, like members of parliament, don't deliver. MPs don't deliver. I hope there are no members of parliament in the audience. But MPs don't deliver, so mento posterior doesn't deliver. And so when you have face presentation where the chin is next to the sacrum, that won't deliver, even if you were to do a forceps. And of course, if you have face presentation, for obvious reasons, you're not going to do a vacuum. If you have to do something, it would be a forceps delivery. All right, and then there are fetal indications necessitating that you do whether forceps or a vacuum, and that is if there is fetal distress. So fetal compromise necessitating immediate delivery, but the lady is in the second stage. Of course, if she's still in the first stage and the cervix is not fully dilated, you go for cesarean. But if she's in the second stage, then you can attempt vacuum or forceps extraction. And of course, again, if she is in the second stage, a non-reassuring fetal heart tracing and non-reassuring CTG. Again, assuming that she's in the second stage. In fact, we're going to have a session dedicated to CTG cardiotocography interpretation. Okay, so we'll go into that in more detail in that particular session. Now, so you've had your indications and you are called to the delivery suite, and you know, the midwife tells you that this lady has been in labor for over 2 hours. The CTG is starting to become non-reassuring to go for an instrument delivery. Now, of course, there are some obvious, but I mean, obvious is not always common sense. There are some prerequisites which need to be there if you're going to go for forceps or vacuum. And these are that you need a vertex presentation, so it needs to be cephalic, right? Now, at least it needs to be the head presenting. As I said, there are some exceptions like a face presentation with mento anterior, but the head needs to be in the pelvis. Also, you need complete dilatation of the cervix. I mean, you can't do an extraction if you don't have complete dilatation of the cervix. If you have a multip, especially if she's a grand multip, and the cervix is at 9 centimeters, you might, I say big might, do a vacuum extraction. If she's a multiple, the assumption that the cervix will like give way. Of course, just be careful that if you're going to do a vacuum on a cervix which is still not fully dilated spine, that with the cup you don't catch parts of the cervix because you'd lead to a torrential bleed because of tearing of the cervix. Of course, you need to have the membranes which are ruptured, so the water must have been broken. There is no known cephalopelvic disproportion, so that's why previously I mentioned the relative cephalopelvic disproportion. So if the pelvis is, let's say she has had previous trauma, previous fracture in the pelvis, we already know that the anatomy of the pelvis is not normal, then, I mean, it's unlikely that the head will engage, and if the head is still at 5/5, therefore you can't do your instrument. And very last but not least, also a willingness to abandon the procedure. What do I mean? So, as we will see, I mean, including with vacuum, but even with forceps, you attempt your delivery. You have a certain time where it's safe to maybe have multiple attempts, especially with the cup if it is popping off, for example. But you need to be practiced enough that you would know when to abandon the procedure and of course go for section. And because, for example, if you have the cup and it pops off 3 times and you keep on reapplying it and it keeps popping off, you're causing more damage than you're not achieving anything. You're risking a lot of damage. Same with forceps. I mean, if you apply the forceps well and you are, pulling and there is no descent, you have to abandon the procedure. Okay, and as I said, go for section. So that is also very important. Okay, all right. So the engagement. So this is, again, I'm sure you're all familiar, those of you who have spent already some time on labor ward, that by engagement, it means that the passage of the piparated diameter of the fetal head, baby's head, has passed through the pelvic inlet, and that the leading edge of the fetal skull is at or below the ischial spines. So as I said, if you have the baby's head, which is fully palpable, above the pelvic brim, then you can't go for instrumental delivery, even if it's at 4/5 or 2/5. From 2/5 onwards, then because the leading part would start approaching be at or hopefully below the ischial spines, then in that case, it is more likely that if you do a vacuum extraction or a forceps delivery, that you'll be successful. So examination of the mother is very, very important. Okay, so when we talk of assisted deliveries, there are 3 types. You've got the outlet forceps or vacuum, when the pelvic skull is on the pelvic floor and the scalp is visible between contractions. Okay? You've got the low forceps or vacuum, sorry, this needs to be an or, where the fetal skull is at or below +2, below the ischial spines. Okay? And mid forceps or vacuum, where the head is engaged but above the +2 station. Now, in modern obstetrics, you don't even go for mid forceps anymore. You don't. I mean, because cesarean section in that case would be deemed more safe. So what you do is either the outlet or the low forceps. I mean, or vacuum. And again, I mean, overall, if you were to ask different obstetricians who, do shifts on the delivery suite, overall, the vacuum tends to be the instrument of preference for a number of reasons. Probably the most common being because it's considered safer in terms of maternal and fetal morbidity. It doesn't mean that there are no risks, but by the end of today's session, with the techniques that we're going to be mentioning, you'll see that it all has to do with safety. Because as I said, I mean, the Voicom, if not applied properly, and if instead it's applied instead of in the baby's head, I mean, part of the rim is on the cervix, and you're pulling, you're going to be tearing the cervix and causing a torrential bleed. And when it comes to efficacy, because the forceps that we use nowadays are the Samsonov bands, which are not rotational, the Vacom is the only one which can allow rotation, because as you're pulling on the baby's head, you're helping with further descent and rotation. So that's why it's deemed safer and more efficacious. Or, compared to metal cups, they are overall thought to minimize maternal and fetal trauma. I'm saying thought, I mean, okay, when it comes to fetal trauma, because they're soft cups, the risk of damage is a bit less. But the risk of maternal, although less than with metal cups, as I said, you still need to apply them properly. If you're catching part of the vaginal, part of the vaginal wall, or part of the cervix, you can still cause tears. Remember, during delivery, during labor, all those tissues are very edematous, very vascular, and very likely to bleed if torn. Metal cups, I mean, if you're delivering an occipito posterior, they tend to be a bit more preferred because they are considered to help more for rotational problems, to turn the OP into an OA and therefore help with the descent. However, from personal experience, I've used soft cups even for OPs, and you see the beautiful rotation happening, because I mean, soft cups can still deliver the same pressure. You achieve the same pressure as you do with the same suction pressure as you have with metal cups. Maybe the other difference is that metal cups, they tend to come in around 3 different sizes. So you've got the very small, the middle, and the larger. Soft cups, overall, they tend to be all the same size. Okay, so are there any questions so far? Let's go back one. I see that there is something in the chat, so I'm just going to have a look at the chat. Okay, so good afternoon, all right. But are there any questions so far?
Not at the moment, Prof. I don't see any in the chat box yet.
Okay.
Yes, please. So we can continue.
Let's move on. Yes, let's move on. So going to share and share this. Okay, so now we're going to go directly into the procedure and the mnemonic. So as I said, the mnemonic. So mnemonic is when you have, a sentence or a phrase which helps you remember something which is maybe more complicated.
Hi, Prof.
Yes.
Sorry, I think Nana has a question in the section.
Sorry. Okay. Yes. So let me stop sharing. And let me just. Okay. So the vacuum types, rather than that we don't use, but that we use. So there are two main types of vacuum extraction. So you've got the metal one, the metal cup, okay, which you normally find, in every hospital, and that's usually which is attached to the electricity, and when you switch it on, it does that sound where it removes the air in order to create vacuum. And then you also have the soft cups. So the soft cups are usually either of silicone or of a type of plastic called bakelite, which are the kiwi cups. So you can use both. The difference between the two mostly is that, for example, with the soft cup, like the kiwi, you don't need electricity and you don't need a setup. So basically, if you rush in the delivery suite and you don't have many people around you to help you to attach the machine to the electricity, etc. Having the kiwi, which has a manual pump, might be easier. I mean, but for example, in our hospital, we have both. We've got the manual ones, the kiwi, and we've got also the normal metal one. The difference between the two is that one is disposable. Okay, so it might turn out a bit more expensive because the plastic one, the manual one, is disposable, so you can't use it after having used it for one patient. The metal cup, of course, can be sterilized and can come in different sizes. So we still use all. Rather than vacuum types, it's the forceps, the key lens forceps that we don't use anymore, the key lens. I'll go back and share and I'll show it to you. Actually, I have another picture of it coming up soon. The key lens forceps, I write it here. The key lens forceps, that's the one that we don't use anymore. It's the one which, the key lens forceps, the one which is there to allow rotation of the head while still in the pelvis. But we stopped using that now for at least 20 years, just because, of course, it was causing a lot of trauma, particularly to the maternal pelvis. So that's the one that we stopped using. Okay, so hopefully that was clear, Anna.
Thank you very much, Prof.
Okay.
Yes,
So,
I think there are no more questions, so we can proceed.
thank you, Abigail. Thank you. Okay. So just waiting for it to share. Okay. So the mnemonic for vacuum application, which is as easy as ABC. Okay, so it's actually A, B, C, D, E, F, G, H, I, J. And every letter stands for something. So I find these very helpful. That's why I want to extraction in this case, by having something which is literally at the tip of your fingers and you know it's literally by heart, you are more likely to do it the proper way. And what's even more beautiful, if everyone on delivery suite knows that if everyone knows that mnemonic, then you work as a team. And ultimately it's safer for the patient, safer for the baby, and safer for everybody. Okay, so the A. So the A stands for you ask for help. And you might say, but I'm the senior obstetrician. They have asked me to come and help, so why should I ask for help? So remember, and for example, if you are the senior obstetrician who have been called in and you already have your midwife and your nurse there who have been helping the patient and you come in, you just make sure that you have your team around you. And also, if you're going to be doing a vacuum extraction, you need also to make sure that the pediatrician is alerted. Even more so, as we'll see, if you're going to do a forceps delivery, you need to make sure that the pediatrician is there. Or at least if you don't have a pediatrician straight away, but at least one of the midwives who is familiar and experienced in neonatal results is there. So you ask for help. You address the patient. So what does that mean? That's the second A, address the patient. Imagine, this patient has been delivering, she's being followed up by her midwife, by her nurse, and then suddenly, she sees a lot of people rushing in the room. You need to have her on board. You need to tell her what you're going to do so that you minimize her risk of becoming very scared and possibly uncooperative, because remember, she has to cooperate. She needs to be pushing while you're pulling with your vacuum. So you address the patient, tell her what's happening and that you're going to apply a cup on baby's head in order to help her hasten the delivery. And also keep in mind the analgesia or anesthesia. So if, for example, she's been in labor and she hasn't received any analgesia, right? Or she is already on anesthesia, but maybe because she's been pushing, maybe the epidural has been switched off, you might consider having it switched on. Or at least giving her epidural block, for example, or some local anesthesia, especially because, as we'll see soon, with vacuum, you might need to consider doing an incision. And it's better to infiltrate the perineum with anesthetic. You're pulling with and then having to coordinate how you're going to infiltrate to then do an episiotomy. So that's your A. So ask for help, address the patient, and check about the analgesia anesthesia. The second important thing is you need to make sure that the bladder is empty. Now, this might come as obvious, all right? I mean, the patient, during delivery might have been to the toilet, but remember, I mean, if she's been pushing for 2 or 3 hours, she has a drip, the bladder might still, might have refilled again. And if the bladder is full, of course, I mean, that's going to impair the descent of the head. So you need to make sure that the bladder is empty. So you might want to you catheterize, okay? But if you catheterize, make sure that the balloon of the catheter is not, full, because then the actual balloon might also inhibit the descent and might also obstruct the balloon of the catheter. The other important thing, that's the C, is you need to make sure that the cervix is fully dilated. As we said, I mean, you are going to apply your vacuum or your forceps, especially the forceps if the cervix is fully dilated. Exception that you might consider is if she's a grand multiple, like, she's had babies before, and the cervix is 9, and as you're examining, like the cervix from 9 is already giving way because it's very soft. So in that case, but otherwise, the cervix has to be fully dilated, especially if it's her first baby. ABC. So we've asked your help, we've checked that the bladder is empty, and we've checked that the cervix is fully dilated. Then comes your D, determine the position, right? So as you are doing your vaginal examination and ensuring that the cervix is fully dilated, you want to know the position of the baby. You want to know where the anterior fontanelle is, where the posterior fontanelle is. You want to check whether there has been molding, right? I mean, especially if she's been pushing for a number of hours. And this is also important, as we'll see very soon, with the vacuum, because you need to know where the anterior fontanelle is and the posterior fontanelle is, because you're going to be applying the cup of the vacuum on a position called the flexion point, which is basically closer to the posterior fontanelle than to the anterior fontanelle. In addition, remember the anterior fontanelle in a newborn, the anterior fontanelle is still not closed. So you don't want to put your cup on the anterior fontanelle, and as you're applying pressure, of course, you are applying pressure on the membrane covering the anterior fontanelle. And what lies underneath, of course, there's the brain, and you don't want to damage the brain. Okay? So by doing your cervical examination and your internal examination, you're determining the position of the baby's head. And also, you're assessing to check whether the ear is palpable, to check, basically if there is any asynclitism, whether the head is in the middle or not. In this situation, you don't even feel the baby's ear. And molding is also important. The, yes. So if this baby be a bit of macrosomia, right? You need to prepare yourself and be on the lookout just in okay. So being vigilant, being on the alert. Okay? Incidentally, we have another session on shoulder dystocia, which also is coming up very soon. So far we've done A, B, C, D. Then E. E is your equipment and extractor ready. So what do we mean by this? By extractor ready, so you're going to decide, okay, which extractor I'm going to use. Am I going to use the metal cup? Am I going to use the soft cup? If, of course, I need to use the one which is attached to the electricity, like the metal one, you need to make sure that the machine is attached to the electricity and that the pump is working. The other equipment that you're going to need, given that you might need to be doing an incision, you need to make sure that your vaginal pack is ready, with your scissors and your swabs, etc. And the other important thing that needs to be ready is that your resuscitator is nice and warm, because once this baby is born, the baby needs to go to the resuscitator. Ideally, also the pediatrician has arrived by now. Then comes the S, which is they're all crucial, but this is probably the most crucial part, because now you're going to be applying the cup. So the cup needs to be applied over this flexion point. Now, I'm sure a number of you know where this flexion point is, but just as a reminder for everybody, where it is. So basically, you know that the baby's head has sutures, and there is the sagittary suture, which basically divides the right from the left side of the skull. And this flexion point lies exactly at 3 centimeters in front of the posterior fontanelle. So that's why when I was saying that you are determining the position, that's why you need to decide where there is the posterior fontanelle and where there's the anterior fontanelle. And in the ideal situation, it would be occipital, meaning the posterior fontanelle is close to the mom's pubic symphysis, and the anterior fontanelle is close to the sacrum. So this flexion point, by applying the cup over the flexion point, that means that that's the ideal place, because as you are pulling, once the cup has attached to the head and you're pulling, that's going to promote even more flexion of the fetal head when there's traction. And therefore, there would be more place, especially also if the baby is in the OP, occipital posterior position. Because by applying it over the flexion point, even though the baby is in OP, the baby's head will flex, and that will help the rotation. So as the baby is being delivered, you'll see the beautiful rotation of the baby's head from OP, and the delivery is more expedited. So some more words about the flexion point. So here, this is a dummy, okay, like the doll that we're going to be using. And this would be the posterior fontanelle, and this is the anterior fontanelle. Now we said, and we can see it here better. So there's the posterior fontanelle, the anterior fontanelle. So we said the deflection point lies at 3 centimeters in front of the posterior fontanelle. Now, I mean, the cup, right, whether it's the metal cup or the soft cup, the cup of the vacuum, more or less is usually about 6 centimeters in diameter, right? Therefore, with a radius of 3 centimeters. So if the diameter is 6 centimeters, the radius is 3 centimeters. So that means that if you put the edge of the cup with the edge of the front part of the posterior fontanelle, all right, over the sagittal suture, that will mean that the center of the cup, right, will be right at the flexion point. Why? Because the flexion point therefore lies 3 centimeters in front of the posterior fontanelle. The cup itself, therefore, if you apply it with the edge of the cup next to the edge of the posterior fontanelle, then the center, we've got some echo, means that the middle part, sorry, that means that the center of the cup lies at the flexion point, which is at 3 centimeters in front of the posterior fontanelle. Okay? So this, if you have an OP or on a way, it doesn't matter, because what you don't want is that you have this cup on the anterior fontanelle or close to it, because in that case, instead of promoting flexion, you're promoting extension, and that's what you don't want, because you're going to make them difficult. Okay, so here we've got the baby in the OP position. So in this case, the posterior fontanelle is behind here, and you put the vacuum cup with the edge right in front of the posterior fontanelle. Therefore, the center of the cup will be on the flexion point. Okay, and therefore, when you apply traction, you're going to promote, and therefore more rotation and better delivery. Rotation in the case of the OP. All right, so we've done A, B, C, D, E, F. All right, so once you are happy that the cup is applied in the right position, of course, something important that we need to keep in mind also as we're applying the cup is that with your finger, right, your index finger, you make sure that as you're applying the cup, you're not trapping any vaginal or, of course, cervical, but especially vaginal tissue. Why? Because if you get trapped by the vacuum cup as you're pulling, then you end up tearing the vaginal tissue, which you don't want. Okay, because it will cause bleeding and bleeding sutures, infection, etc. Okay, so once you are happy that the cup is on the flexion point, you switch on your vacuum till you reach the pressure, and it's usually you start at 0.2 and then check again to make sure that you make sure that you're not trapping any tissue, and then you go up to 0.8. You don't exceed 0.8 because, of course, then you're applying too much pressure and risking damage to the baby's head. So once it's in place, then you wait for the contraction. That's why you need the mother, you have addressed the mother and that she's on board, so she cooperates with you. And upon the start of the contraction, you apply gentle traction. Now, gentle traction at right angles to the plane of the cup. What do I mean by this? So the cup, right, will have a cable, right? So whether you're using the metal cup or the plastic cup, I mean the soft attached to a cable. And that cable needs to be at right angles to the cup, because if it's you start pulling, that cup will pop off. And every time it pops off, every time it will cause damage to the baby's head. And also every time you have to start again, like by applying the cup. And of course, you're wasting time, because I mean, if you want to expedite the delivery, you're wasting time, precious time, because the cup is coming off every time. So, of course, you avoid trying to rotate yourself. I mean, if the head has rotated to rotate on its own, you don't want to apply it to the side. You want the cup to be in the middle, over the flexion point, in the middle, over the sagittal suture. And you don't want to go at an angle other than right angles. You don't want to bend, because that will cause detachment, the pop-offs. In fact, if there are pop-offs, and so this is the vacuum delivery, and I'm sure many of you have seen vacuum delivery, and the cup is over the flexion point, so you see it's closer to the posterior fontanelle than to the anterior fontanelle. You want to stay away from the anterior fontanelle. So if there is a pop-off, is one of the reasons why you have to halt. But very importantly, traction after the contraction is over. and you keep the cup there, of course, and you keep, everything in position, but you don't apply traction. You wait, and you wait for the next you might want to reduce the pressure a bit. So whether you're using manual or the electric, and you might go down from 0.6, but not much below that because you don't want the cup to come off. It's very important that you hold the procedure if the cup comes off 3 times. So whether it comes off 3 times because of you didn't apply it well, or you're pulling in the wrong direction, whichever that it's popping off, you abandon the procedure if the cup comes off 3 times. Or if the cup is in place, but there is no progress in the descent after 3 consecutive pulls. So by this I mean, so if you're pulling, and contraction is over, you stop, then the contraction again, and you pull. But there is progress. So even if after 3 consecutive pulls, there is no delivery yet, but there is progress. You can see that there is descent, and the descent is not just because the head is now more molded, but you can which is actually descending. In that case, it's okay to continue. But if there is no progress, so you are stuck at the same place after 2 consecutive pulls, you abandon the procedure. And very importantly is that in total, the cup stuck to the baby's head, you don't go beyond the 20 minutes. Because if it's taking you 20 minutes, meaning that the cup is stuck to the baby's head for 20 minutes or more, then you're risking trauma to the baby. And in fact, fetal injuries, in reality, if you're applying a vacuum delivery, delivery needs to be within less than 10 minutes in reality. If you're still at it beyond 10 minutes and you're applying the right technique, then there is very likely to be some degree of pelvic disproportion or some impediment to normal delivery, and you need to go for section. So that's your H. So far we've done A, B, C, D, E, H. The I is, so as you are applying traction and you see that the perineum is starting to be stretched, okay, and maybe it's about to on the verge of tearing, you might want to do an incision in episiotomy. So that's why in the very beginning, we also assess the need for possible analgesia, especially because if you need to do an episiotomy and you want to infiltrate with anesthetic, it's better by then. Okay, just to make sure you're still hearing me. You are still hearing me, yes?
Yes, Prof, we can hear you.
Yes, thank you, Abigail, thank you. Very often, the good news is that for vacuum, very often, since the vacuum doesn't occupy so much space, you very often can get away without needing to do an episiotomy, and there is no tearing. However, if you're suspecting that this is going to be, there might be a shoulder dystocia, you might need to incise, and you incise not because the incision per se is going to directly help the shoulder dystocia, but if you need to perform some maneuvers in order to dislodge the shoulder, by having an episiotomy, it makes life doing the maneuvers. As I said, then we will have a separate session on shoulder dystocia, and when we come to that, I'll remind you of this and what we're talking today. Once the head is delivered, actually, once the jaw is reachable, so the head doesn't need to be completely out, but the jaw is reachable, meaning that the widest part of the head is out, then you remove the vacuum. So you remove the pressure, and then you don't just pull it off, but because usually after reducing the pressure, there is a little, some few minutes where the cup still remains attached to the head. So you wait for it very often to fall on its own, or you gently remove it. So on the first time that you deliver the baby, the cup is still attached, and then you remove it for presenting the baby to the mother. So that is your A to J for vacuum. As I said, a normal consequence of vacuum extraction is what we call the chignon or the cephal hematoma. It's very common. All right, it looks a bit scary at first for the mother, but before presenting the baby, you reassure her that this would be temporary. Usually, it's over within 48 hours and doesn't really have any consequences. However, so that is your cephal hematoma. However, it might look a lot, especially from the prolonged delivery and the cephal hematoma. However, of course, what you want to avoid are these two: the subgaleal hemorrhage, that is the hemorrhage which is under the dura, basically within the brain, and the extradural hemorrhage, which is basically a type of intracranial hemorrhage. And because these two, they have serious consequences on the baby, including cerebral palsy, and those are what you don't want. And that's why we emphasize a lot on all the safety precautions that we've been mentioning. So after doing your vacuum delivery, and of course, assuming that there's no shoulder dystocia, the rest of the body is out, and you do proper cervical and vaginal examination to assess for tears. You want to look for evidence of any tears or bleeding in the mother. In the case of the baby, you want to also inspect the baby for evidence of birth trauma. So while it is normal cephal hematoma and even some degree of scalp emphysema, so the scalp is a bit puffy, but what you don't want is the subgaleal hematoma. So that's why you need your pediatrician to assess the baby after delivery. The increased bilirubin and therefore the postnatal jaundice can happen. Especially as the cephal hematoma is resolving. Of course, you can get postnatal jaundice even in a normal delivery where you didn't need to do assisted vaginal delivery. But of course, if there is a cephal hematoma, as the fetal liver, as the neonate's liver is processing and that it's getting rid of those red blood cells, and there might be an increased risk of hyperbilirubinemia. So you might need to follow that patient till that baby till the bilirubin goes down to normal levels. Some disadvantages of using the vacuum. It may take longer than the forceps because the force that you're applying is a bit less, and you need the maternal cooperation. And of course, there has to be minimal cephaloperiferic disproportion. I didn't know cephaloperiferic disproportion. You need to make sure that you're placing it properly and also pulling properly in order to avoid losing the vacuum and therefore having the pop-offs. There is a small increase in cephal hematoma, and improper use can be detrimental. It can lead to subgaleal hematoma or intracranial hemorrhage, as I said. And therefore, extraction in the same way and make the notes, your operative note, in the same way as you would do for forceps delivery. So you need to document like preoperatively why you decided to go for vacuum, your postoperative diagnosis to assess um, to the fetus or to the baby, the operation itself, the history, and document what happened in the first stage, second stage, the procedure, and also the third stage, after delivering the placenta. So those are very important. Now, I'll move on to the forceps because there are many similarities. Actually, the same mnemonic ABC attention to when applying the actual forceps. So there are many forceps, as I mentioned, and the ones which are, we typically use. I mean, if we have to use, because as I said, I mean, not all obstetricians are happy using forceps, but there are situations where you need to have the forceps. So you need to be familiar with them. Is the Simpson, which is this one, the Simpson or Neville Barnes? It depends. Simpson is the American. And the others, including the Keelans, we no longer use. And I mean, these also we don't use these anymore. Okay. So when it comes to applying, so as I said, the initial part is similar. So A, ask for help. You here definitely need your pediatrician, plus you need help. You need your midwife, you need your senior obstetrician. If you're not the senior obstetrician yourself, you explain to the patient, right? Even though in this case, right, you can pull even without her pushing, which is not ideal because ideally she pushes as well, but you need to explain. I mean, patients get very scared seeing these metal blades, being fleshed in front of them, and you need to explain what's happening to the patient and partner. I mean, if they are partners in the room. And that there is the adequate analgesia. Because as we see in forceps, it's almost inevitable that you have to do an incision, you have to do an episiotomy. Again, bladder needs to be empty, cervix needs to be fully dilated, and here it has to be fully dilated if you're applying the forceps. D, you have to determine the position. Again, I mean, you have to see where the are, and also think of shoulder dystocia. So A to D is similar to the forceps. Actually, this has to be forceps. I'll correct it in the slide that I will send you. And now when it comes to application, so the E and the F. So E is the equipment ready. So you need to decide, okay, which forceps I'm going to use. I'm going to be using the Simpson's forceps, okay, which has the lock here, and it has the two plates with the cephalic and the pelvic curve. But I also need to make sure that my vaginal pack is ready, all right, especially with the scissors, because I'm very likely going to do an episiotomy. And you need to have your resuscitator switched on. And F is for forceps. Now, here I'm going to spend a few minutes just explaining applied. But just before that, make you familiar with the different parts of the forceps. Why? Because when we'll be doing our hands-on session, you need to be familiar a little bit with the different parts of the forceps. So if we're looking at the forceps from above, so first of all, the forceps make sure that when the nurse midwife gives you the forceps, even though maybe, they've come sterilized from CSSD and, you're opening a new pack, you need to make sure that you have a pair. Why? Because it's not the first time that you might have a pair which are both right plates or both left plates. So before starting to apply, you put them on your operating table and make sure that they fit. And the tip is known as the toe. So this is like compared to a foot. So that's the toe and that's the heel. If you see the forceps from the side, there's the toe and there's the heel. And as you are putting one on top of the other to make sure that they fit, you would see this pelvic curve with the toe pointing upwards and the heel over here. So they kind of don't fall to one side or the other. They stay still. Now, in order to make the forceps a bit more lightweight, there is a fenestration, that there is a hole, basically, not only to make the forceps lighter and easier to manage, as we are handling it, especially when we are extracting the baby, but also because this will allow us to see the baby's head as we put the forceps on the baby's head. And we need to see it in order to make sure that we're putting it in the right place. apart from the pelvic curve, you also have the cephalic curve, which is essentially where the baby's head will fit. Okay, so that's why we say the Simpsons or Neville bone has two curves. It has the cephalic curve. Okay? Then there is the shank. So this shank is what connects the blade, this we call the blade, to the part where you hold, so the handle. Okay, and there is a lock. You have the lock because these basically lock into each other. Okay, in order to give you more stability, and you don't risk one blade, as you're pulling, sliding off the baby's head and damaging the baby's head and causing, for example, facial palsy. So how are they applied? So as I said, first, before even putting anyone, to the patient, you need to make sure that you articulate and hold them in position and make sure that they are a pair. Then you disarticulate, okay? And you start with the left blade. The left blade will fit in your left hand. And basically, this is going to go to the left side of the mother's pelvis. So what do? You slide your right hand into the patient, and like that, you are protecting the maternal tissue. And literally, like a pencil, like holding a pencil, like with a pencil grip, you don't need to apply any force, you're not ramming the blade then. You literally put the left blade towards your right hand. Your right hand is protecting the maternal tissue. And with the finger, with the thumb of your right hand, you push the heel of the forceps inside. Is the left blade to the left side of the maternal pelvis, just go towards the vulva. The shank initially is vertical, but then as it fits in, it goes to 90 degrees, sometimes even lower than that, depending on the baby. And after you apply the left blade, you could do the same thing for the right side. So basically, you take the right blade in your right hand, with your left hand, you protect the maternal tissue, and then you point the you pick the right blade with your right hand, and with the thumb of your left hand, you guide the blade inside the pelvis. And once you put both in, you are the two blades, and like that, they are nicely fitting. Now, I know for those of you who have never done forceps, this might be, a bit difficult to picture. But I mean, I've got some pictures here, and as I said, I promise you this is one of the stations that we will be spending time on when we meet face to face. But I just need you to be familiar with the terms, because I'd rather use the time when we're together to do the hands-on, and all of you will get the possibility of at least doing one forceps on the mannequin, on the plastic doll. So here, the left blade on the left blade, other, using your right hand in order to push your right hand to protect the maternal tissue, and with your right thumb the blade inside. You're doing then the same thing with the right blade, okay? And once the blades are in position, as you are about to look, right, you, and definitely before you start pulling, you need to check your position for safety. The PFS is another acronym within the acronym. So the position for safety basically stands for, you need to make sure that once you've applied the blade and before you start pulling, you need to make sure that the posterior fontanelle is midway between the shanks, 1 centimeter above the plane of the shanks. I'm going to show you a picture of this. Okay, but you need to basically make sure that the posterior fontanelle is in the midway and it is above the plane of the shanks. I mean, here we're talking of in this case, it would be an OP position, basically. Sorry, it would be an OP position, yes. So those holes within the blades, they need to admit no more than one fingertip. Because if they are admitting more than one fingertip, basically means that the toe of the blade is not snugged around the baby's head, but actually pushing into the baby's face, and you're risking trauma, including palsy, patient of palsy. You need also to check the baby's sutures of the baby's skull sutures and make sure that they are, you've got the sagittal suture in the middle and the lambdoid are above and they're equidistant from the surface of each. Show you a picture to be able to picture this a bit better. So here you've got the two blades, right, which you've inserted. You've inserted first the left blade and then the right blade, and you know that they fit. And before starting to apply the sagittal suture, you need to make sure that the above the shanks, and you check that on both sides the fenestrations you can fit no more than one finger. I understand for those of you who had never done or seen a forceps, this might, sound a little bit confusing, but as I said, I promise you that you'll all have the chance to practice and see this live, on a doll, and then it will make a lot of sense. See, it's there so that before you start applying traction, you are making sure that you are avoiding damaging maternity tissue, but even more so the baby's head. Basically, once positioned, the tip, that is the toe of the forceps, should be underneath the baby's chin. I mean, if this is not, it's not, it's higher up here, you're going to be pressing over the maxillary area and, nerve gets damaged. So once the forceps are applied and you're happy that they're positioned well, you've checked your position for safety, then you start your traction. Now, depending on the indication of why you did the forceps in the first place, in the ideal situation, you ask the mother to push while you are doing your traction. However, we know that with forceps, you can also apply traction with traction happens, we call it Pajot's maneuver. So basically that means that you are pulling along the pelvic curve. Again, you do it in order to avoid damage to the mother and also to make sure that the baby's head is kind of flexing as you are delivering the head. So it's a J-shaped arch, like the traction follows a J-shaped arc. So the initial traction is downwards and then it sweeps upwards. And so you're using both hands. So one hand is right. If you're right dominant, use your right hand to pull. With the other hand, the unused hand, that is the left hand, you cause and basically you push downwards. So horizontal outward and vertical downward. And like that. So with that, so the line of pull, you've got the horizontal outward and the vertical downward. Like that, the blades and the handles are first moved downwards and then upwards. So it's like an arc. Again, you will see this even on the mannequin when we do the practice. It's called Pajot's maneuver. Okay, so basically, once you are, doing your traction, the gentle traction, that's the G, the H. As you are completing your traction, the handles end up being vertically elevated because they follow this J-shaped pelvic curve. As the head is crowning, and very often you need to do an incision. In this case, you need to do an episiotomy in order to avoid a tear, 4-degree tear. So it's better to do an episiotomy. And the jaw is visible, you can remove the forceps. So you remove, and when the jaw is reachable, and you remove the blades in the reverse way that you've applied them. So you've applied first the left blade and then the right blade. You remove first the right blade and then the left blade. The reason why you follow this left, right, right, left is because of the way that the lock is positioned. And again, you'll see that when we do it in Of course, like we did for vacuum, you need your post-op, your post-forceps care. You need to assess for any damage to the mother, and you need to assess for evidence of birth trauma, which unfortunately, I mean, the forceps, if not applied well, can cause quite a lot of trauma. The point of this mnemonic per way and minimize trauma. Unfortunately, you can still get preparations, you can get patient and see. There could also be fractured clavicles, of course, if there has been a lot of traction. I mean, especially if the mother was not pushing and you are pulling, and I mean, that would be quite extreme. But what is definitely very common, and you reassure the mother that they are benign, is that there are forceps marks. I mean, they are normal, they are benign, and same as for the chignon, I mean, they normally disappear by 48 hours. So which one would you go for? Instrument of choice. Many obstetricians go for vacuum. I mean, it's a fact because it's easier to use. You're following the pelvic curve automatically. Overall, there is less force applied to the head because if there is too much force, it's going to anyway pop off. And beyond 0.8, you know, the safety mechanism within the instrument. There tends to be, if applied well, fewer cervical and vaginal lacerations, and also technically you can apply it without certain knowledge of the head position, like if you're not sure if it's an OA or an OP. But of course, I mean, it's not ideal, you know. The thing is, of course, you can't, for example, apply it for someone who's preterm because you do increase the risk of intracranial hemorrhage. Forceps, I mean, would be the instrument of choice if you want to affect a more rapid delivery, especially if the mother is not cooperative or if she's getting unconscious, for example, and can be, very exhausted, can be used in mild presentations. Like, for example, if it's a face presentation, of course, you can't use vacuum if you have a face presentation. Remember, you can deliver face presentation only if they are mento anterior, because MPs deliver, as I said. And it can also, well, for rotations, you really, I mean, this I need to correct it. The forceps, the Simpson, you can't really use for rotations because it's the Neville Barnes and it's the Keelans, but the Keelans we no longer use. So I'll correct it. So sorry, I left this here. It cannot be used for rotations, forceps. So in summary, and that brings us towards the end, percent of deliveries certainly in Europe require some help, require either forceps or vacuum. Their care providers should be familiar with the instruments and they're considered as part of the skills and drills. The A to J mnemonic provides a systematic method so that everyone knows, you know, from the most junior midwife to the most senior obstetrician. So everyone knows what to do and assist. Okay, so even though it's the obstetrician doing the delivery, but if everyone knows the mnemonic, you know, as soon as the forceps is going to be applied, the midwife will make sure that there is a stair is open, and that the pediatrician has been called for, etc. And it's important that providers are aware of complications and contraindications to these procedures. We managed, I mean, yes, with just a few minutes delay to you. And I apologize again that we started late, but I think we caught up and we had time to um, to uh, to go through the slides. And I see that there are some questions. So let's see. So Ellen, so how one does determine which forceps to use at any point in time? So basically, which forceps to use um, in in our practice, meaning in Europe, and I would say in most obstetric units, we go for Simpsons and Neville Barnes are the same. It's just that the Simpson is like the American term, was invented by Simpson, was American, and the Neville Barnes is the English one. But they're the same. They both have a cephalic and a pelvic curve, and they are used for outlet extractions, and you don't do rotations. So as I said, I will correct that mistake that there is on the slide. The Wrigley's, which is the one which looks like the Neville Barnes or Simpson, so same blades and same curve, but they have a shorter handle. Those are used when if you're doing a cesarean section, so you've opened the uterus and the head is very deep in the pelvis. So some obstetricians, instead of using their hand to scoop out the head, they can use the Wrigley's. It's personal preference. And when must one abandon forceps after application? Very good question. Thank you for asking that, because we mentioned about the vacuum that you abandon it if there have been three or no descent after three pulls. So with forceps is quite similar. So effectively, if you have three pulls and three consecutive pulls with no descent, you abandon because you are then suspecting, cephaloperitoneal disproportion. And if you've been applying the forceps for more than 20 minutes, okay, and that's very important. Pop-offs, you don't have pop-offs, but because if you do get one blade or the actual blade sliding out, it means that you haven't applied them well in the first place, and you just abandon. And if the blades just come off, with the pull, yes. So that is when you should abandon the forceps. So thank you for asking that question. So are there any other questions?
Yes, please. Hi, Prof.
Yes, hello.
Does it have any effects on the pelvic floor muscle function? Does it have any effects on the pelvic floor?
Okay.
That's what I wanted to find out.
Yes, thank you. So in the case of vacuum, not really, because already, you are not really increasing anything. The vacuum, the fact that it attaches to the fetal head, you're not really increasing, let's say, the space. You're not making use of the space within the pelvis. So the risk of pelvic floor damage, by adding on the vacuum is almost zero, basically. It's zero. I mean, for damage, it would be more because of the labor itself, let's say. But in the case of the forceps, because the blades themselves, so not only do you have the fetal head now, but there is the blades around the fetal head, right? Which, of course, they're occupying the pelvis. And because although you use all the precautions in order that they are applied well, there is definitely an increased risk of damage to the maternal tissue. We do the position for safety to minimize that, but it's not all in the control, and problems can still happen. So yes, there is an increased risk of pelvic floor damage. Also because in the case of forceps, as I said, I mean, although in the ideal situation the mother is pushing while you are pulling, but I mean forceps, you tend to apply more force, and you can also apply it if you don't have maternal cooperation. So in that case, it means that you are pulling on the baby's head and on the pelvic floor. So yes, there is an increased risk of pelvic floor damage, and it's important that patients, after any delivery, but especially if there has been an instrumental delivery with a forceps, that they do their Kegels exercises, and that you teach them about the Kegels and the exercises, which in the ideal situation they would have been doing during pregnancy in the ideal situation, but very important that they continue doing them after delivery. And the post check, I mean, you ask about possible incontinence and dyspareunia, and incontinence could be both urinary. And remember as well that with there is an increased risk of tears because they're occupying more space and they're stretching the pelvic, the perineum even more. So that's why it's recommended to have, which there you have no control on. It might extend and might actually also cause even more pelvic floor damage. So thank you for asking that question, Abigail. Very good.
Thank you, Prof. And please, if there are any questions, you can kindly type it here so Prof will just read and answer you.
Yes. While waiting for those, can I ask a question? So in your practice, what do you usually go for? Vacuum? Do you usually go for forceps? Or what is, if you want to expedite the second stage, what is the commonest go-to?
Oh, okay. So in my practice, the one that I've seen so far is a vacuum.
Mhm.
Yes, please. That is what I've seen as used before and was successful.
Okay.
Yes. It was just one time that it was not. I think it was after the 3 pop off, and then we had to,
Go for
yes, please.
C-section.
Yes, go for C-section. Yes, please.
Yes.
Yeah.
And that, thank you, actually reminds me. Yes, thank you, Ellen, as well. That also reminds me that, I mean, there are some situations where some obstetricians, after doing the vacuum and like there are the triple pop-offs and they have to abandon they might be tempted to go for the forceps. I don't recommend that. I mean, because they're, you're abandoning the vacuum. It would be risky to go for unsuccessful. It's very likely that the um, the forceps is going to be unsuccessful unless it's a case of maternal exhaustion or rate at all. I mean, she's maybe fainting, and and you are you see that there is possibility for forceps, but I think I've only seen that done once, and it was a super emergency situation. Outcome was not good. I mean, there were problems with the fetus and a lot of trauma to the mother, and it's definitely not something that you would recommend. And that if there's a failed vacuum, you go for forceps. You just go for section.
Sure, Prof. Thank you for the add up. Are there any more questions, please? Just for some few minutes, are there any more questions? And while we wait for that, IT, can you put on the next session so we could remind ourselves, which is on this Friday?
It's this
Um,
Friday, and
yes,
we are
Prof.
doing a CTG interpretation. Now,
Yes.
I want to prepare you from now that when we're going to do the CTG interpretation, it's going to be a little bit more of a tutorial, meaning that there will be like a mini lecture from my end. So maybe, the first 15 minutes or 20 minutes or so with me talking, and showing slides. But then there are going to be around 10 cases. So like you have a story, like a vignette and the CTG. We'll be going around, and so I'll be asking, for example, one person at a time to unmute and to discuss. So I'm telling you this not so that all of you don't appear and you don't turn up, but actually is it's going to be interactive and not to test you or to put you on the hot seat or to put you on the test. A number of these CTGs, they really open to interpretation. So, if let's say the answer is one way, but you do another way, it doesn't mean that it's wrong, except in some very few exceptions. So if I suggest maybe those of you who might not be, who might be a little bit rusty on their CTG, I would advise you to read a little bit so that like that from our next session we'll get more out of it. Okay. This initially I had been thinking of doing it as one of the face-to-face sessions, but then I realized that we for the face-to-face I'd rather do hands-on, and this is something which could be done in the form of a tutorial. So please, next Friday, yes, I'll be hearing some of your voices, but so far I've been hearing Philip's or Abigail's, and of course, you've had people also typing, but I'll get the chance also to hear your voice.
That's very true. Thank you, Prof.
You're very
So
welcome.
yes, for Friday,
Yes.
kindly go revise your notes on CTG before you come here.
Yes,
Because
exactly.
Prof is gonna ask you questions. Thank you.
But please do come. And we tell them this, it's not a test, okay? So the test is a discussion. And as I said, I mean, many cases, the cases are open to discussion. So, so please. And in the meantime, just a side note, if you're hearing some sounds, it's because there are fireworks in my village. And on Friday, probably there will be even more fireworks because this weekend is the village feast. We in my village it's the feast of the Holy Mary of Annunciation, and from days before they start doing the fireworks. So you'll be hearing some fireworks as well. I don't know if they're heard. I'm here, but I don't know if you can hear them over that.
That's very fine, Prof.
Well,
I think there are no more questions for now.
okay.
So we would like to say thank you again and again for today's session. Gradually we are getting to the end. Our next
Yes.
session is on the 29th, just like we said
Yes.
earlier, on Friday, same time, 3 p.m. But
Yes.
if there are any changes, we'll let you know. That is 3
Definitely.
p.m. to 5 p.m.
Yes.
Yes, please.
Definitely. And
So,
I'll make it a point to be on time. I'll move the clinic to an earlier time or cancel it
okay.
so that I don't leave you waiting. It's really sorry, and I'm really sorry about that. But I mean,
Fine.
I will share this with you. So the patient I was seeing, unfortunately, I found a lump in her breast, and
Um,
it didn't look good. And I needed, I usually schedule 30 minutes per patient, but in this case, I mean, I had to stay a little bit longer with her. But and even when Abigail, when you called me and I told you, yes, I'll be there in 20 minutes, I mean, she was not in very good shape, unfortunately. So it took me a bit longer to
oh,
call her and
wow.
get her referred. But I mean, uh, breast But it's not because I forgot about you or want to leave you waiting. It's just
That's very fine, Prof. Thank you so much. Thank
thank
you
you.
once again. So we
Thank
will
you.
see you on
This
Friday,
Friday.
God willing.
Yes.
Yes, please. And thank you, colleagues, for joining, and have a good evening, everybody.
Same to you. Bye bye.
Bye.
Bye bye.